Thank you so much for joining us this afternoon on a rainy afternoon. Thank you for taking the time to participate in this webinar. Good afternoon. I am Dr. Maurizio Fava. I'm Chief of Psychiatry at Massachusetts General Hospital. On behalf of the Department of Psychiatry, I'm pleased to welcome you to the third session of the MGH Leadership Council for Psychiatry Visiting Day series. We have four outstanding faculty who are here today to talk with us about the topic of today's seminar, which is innovations in clinical care. We're also very fortunate that joining us is Annabelle, who will take about her son, Jack, who's a patient of Dr. Wozniak. We're very grateful to her for sharing her family story today. And later in the program, my friend and colleague, Dr. Lee Cohen, who's Associate Chief of Psychiatry for Philanthropy and Departmental Communications, will lead a question and answer session. Our faculty will be happy to answer any questions you have for them. And now I'd like to introduce you our faculty panelists. Let's start first with Dr. Jeff Huffman, the first speaker. Jeff is our Associate Chief of Psychiatry for Clinical Services at Mass General and a professor of psychiatry at Harvard Medical School. Second presenter is Dr. Janet Wozniak, who's Director of the Pediatric Bipolar Disorder and Research Program, Director of the Child and Adolescent Psychiatry Outpatient Service at Mass General, Associate Chief for Quality and Safety at the Department of Psychiatry, and Associate Professor of Psychiatry at Harvard Medical School. Dr. Erika Greenberg is the Director of the Pediatric Psychiatry OCD and Tic Disorders Program at Mass General, co-director of the Mass General Tourette Association of America Center of Excellence, and instructor of psychiatry at Harvard Medical School, soon, hopefully, assistant professor. Dr. Molly Colvin is director of the LEAP program at Mass General, which stands for Learning and Emotional Assessment program, and she's also assistant professor of psychology at Harvard Medical School. So terrific faculty, we're very excited. And let's start with our first speaker, Dr. Huffman, who has been doing an absolutely incredible job of overseeing the Department of Psychiatry clinical services during the COVID-19 pandemic. So Jeff, could you provide us with an update on outpatient and inpatient services at this time? Thank you.
Thank you very much, Maurizio, and good afternoon, everyone, and thank you so much for joining us. I mean, I think the short thing to say is clinically, we are still up and running, perhaps in a lot of ways now more than ever. On our outpatient services, the majority of our services are actually providing more visits, more care than ever before, even before COVID. No-show rates with our virtual platforms have been extremely low. Patient satisfaction is through the roof. Many patients just love being able to much more flexibly and comfortably have sessions and talk about their mental health in the comfort of their own homes or in other quiet workspaces. And our virtual platforms have been working really well. We're actually using a version of Zoom that's integrated into our electronic medical record. And just to give you a flavor for the kinds and the amount of visits that we're doing, over the past about 3.5 weeks, our departments had 10,400 visits, and 98% of those visits were done virtually. We're able to do a ton of care for patients, you know, at a time when a lot of people just really need as much help as they can get during a stressful time. Now, some patients do need to be seen in person, and as part of our so-called recovery plan of bringing both patients and staff back to the hospital, you know, some clinical groups are slowly coming back, such as those who really need to be with patients to do physical examinations or neurologic examinations, like our neuropsychiatry service. Those programs who do psychology testing, like Dr. Colvin will talk about with her LEAP program, and those programs that provide procedures like electroconvulsive therapy. Now, in addition to these existing programs that can provide in-person care, we've also been able to stand up some in-person and virtual programs newly in the face of this COVID crisis. We have this urgent care clinic, which is really a kind of a new program where we have clinicians who are physicians and psychologists and social workers who who in-person staff a clinic where patients come in and are seen in person. And people can get very rapid appointments with this urgent care clinic. So it lets us take care of people who are really experiencing a ton of distress and really need to be seen in person right now. And we can actually make that happen. And we're actually hoping to be able to expand this to really become a walk-in clinic, to really allow easy access for patients, whether they've been seen here before or not. And it's something we've been really excited about. One of the other new programs that we've been able to stand up is something called the CARES Clinic, which is a program that's a virtual program for employees who are affected by the COVID crisis. And we've been able to develop some of our kind of this program that utilizes psychologists and psychiatrists who have specific training in trauma and recovery, and really lets us bring to bear our expertise for our employees who need help the most. And finally, we've been expanding our computerized CBT, cognitive behavioral therapy service. It's an internet-based program with some phone coaching that allows people to actually learn the principles of cognitive behavioral therapy for depression or anxiety over the internet at their own pace and virtually. And we've expanded this substantially since March. And patients have really appreciated getting these extra tips and skills and procedures at a time when they've been feeling extra stressed. So that's our outpatient set of programs. We've also been really busy in the hospital with more acutely ill patients. Our inpatient unit, Blake 11, has been seeing patients who are COVID positive and COVID negative with many different diagnoses from all walks of life, all throughout the COVID crisis. Our emergency room actually started with low volumes, but is heading way back up. We've been seeing tons of patients in the past couple of weeks who've been coming in and really are in acute mental health distress. And we've been able to provide them with the mental health care that they need. And our medical surgical consultation service has been busy throughout. They've been seeing patients with non-COVID crises, with COVID-related distress, and a very specific neuropsychiatric syndrome related to COVID that's characterized by high levels of confusion. We feel really fortunate at MGH, especially on these services, that with really good training and care and PPE, it's actually the case that across all of these high-touch services with lots of COVID positive patients, none of our clinicians have tested positive for COVID really for many, many weeks and months among those who have been providing these very specific services. And we feel really reassured by that. And actually, it turns out that the hospital may be one of the safest places from COVID. And in fact, the hospital is really starting to encourage patients to come back to get their general medical care here, to really try to make sure people are getting the right medical care and prevent major medical events from happening. So, in short, I just want to say that I'm so proud of our clinicians who have been so flexible and nimble and devoted to providing mental health care to all of our patients, both new patients and existing patients. All over the map. They've been in other states, they've been at home, they've been on our medical services. And we've been so lucky to be able to provide so many different kinds of care in a time when stress and distress and depression and anxiety have been so prevalent given the crisis that we face. So that's an update from our clinical services where, as I said, we're still up and running and as busy as ever. And we're proud for the job that our clinicians have been able to do.
I have to say that, you've been an amazing leader of our clinical services. I've watched you, every day at the end of the day, running those clinical leadership meetings that really are motivated us to do better and better in this area. But I have to ask a question because, you mentioned hospital is very safe. Everybody is wearing a mask. Whereas, if I go to the supermarket, not everybody is wearing a mask or, so I feel a lot safer in the hospital. But my question is, what do you think is going to happen when, in some ways, our clinics will resume their activity? How many patients will say, "Doctor, I really liked the virtual visits. I don't have to drive. I don't I don't have to park the car. I don't have to take the T or whatever."
Yeah.
How much of our activity will continue to be virtual versus resume to be in person? If you have to make a prediction a year from now,
Yeah.
what will it be?
It's a great question. We were talking about this a little bit offline just before we joined the meeting, and there may be a time when so many of our patients say, "Why would I ever, get on the T or drive all the way into the hospital and park, and it's a 3-hour trip for a 20-minute visit? Why would I ever do that?" My guess is that, probably the majority of our care is going to be provided virtually moving ahead. Certainly, there's going to be lots of patients who need to be seen in person or want to be seen in person. But gosh, I think more than any of us ever realized, more than I ever realized, it's really possible to provide both super convenient, but pretty good quality care to people through these video platforms and in other ways that just provides such a better patient experience because they don't have to leave the comfort and relative safety of their own home. And my guess is that it's going to be a hybrid, but that we're going to be doing a lot of virtual care for the future to come.
Thank you, Jeff. Our next speaker is Dr. Janet Wozniak. Janet is a national expert on bipolar disorder and ADHD, and she's an amazing clinician beside being a terrific researcher as well. So Janet, what challenges do you face in diagnosing young children with mood disorders? In 2020, after all the work you've done, to demonstrate that, bipolar disorder can strike children as, as early as, 4 or 5, et cetera. What are the challenges now when you diagnose kids?
Well, I'm very happy to talk about this topic. It's been the focus of my research and clinical career ever since I finished my training decades ago. And it's been a very exciting field to be in because of so many advances and changes that have occurred during this time. Much of it innovations coming from our own research groups. The two big categories of mood disorders that we diagnose throughout the lifespan, depression and bipolar disorder, can be very difficult to distinguish from each other throughout the lifespan. It's actually a clinical problem that is vexing for us even when we see our adult patients. And it's especially a problem, I would say, in children because of the developmentally different presentation that they have. But distinguishing depression from bipolar disorder is critical because antidepressants, the standard treatment for depression, can worsen the course of bipolar disorder, and we would not want to do any harm to cause worsening problems for anyone. Some of the reasons that children may be especially difficult to diagnose include the fact that they have complicated cycling patterns. They can appear different in different environments. They have a disorder that's unfolding in front of our eyes. So it's not as if you wake up and you have the entire syndrome. It gradually can occur and sometimes in what seems like an insidious way, especially in children, but also in adults with bipolar disorder. There's a co-occurrence of many other different overlapping disorders. Anxiety disorders, ADHD in particular are often present. And we're faced with symptoms that overlap across different disorders, most notably irritability. I would say that in many ways, the story of pediatric bipolar disorder has also been the story of thinking about and parsing out the different types and features of irritable mood states. It seems so intuitive that people have irritability and anger of all different types, but in psychiatry, we actually haven't done such a great job of figuring out what kind of irritability is best placed in depressive disorders or with bipolar disorder or with mania. In children, as you alluded to too, we've been limited by the fact that bipolar disorder was not in the differential diagnosis for diagnosing children until we started to do our work and partnering with colleagues across the country and really across the world to demonstrate that bipolar disorder can occur in children. It seems intuitive that if a child could be depressed, that there should be some children who could also have manic moods too, making their disorder bipolar, but yet pre-existing prejudices about children and their disorders, that such a serious disorder maybe shouldn't or couldn't present in such little children, prevented the field from moving forward. Our research now has demonstrated that there's a substantial minority of children who have bipolar disorder. It's probably in the range of 1 to 3% of the general population, but this makes up millions of kids. And in our clinics, the rate's persistently been about 15 to 20% of our referrals. And even though that's a minority of the referrals, I usually say they make up 90% of our headaches and our sleepless nights, because these are children who have really severe symptoms and they need intensive multimodal treatment. So they make use of much of what we have to offer in psychiatry. In order to accurately diagnose these children, we learned over the years that developmentally, these children present with a range of moods, but most specifically, they have a very severe type of irritability. I often say it's capital I, bold face, all large font irritability, angry moods, rageful outbursts, explosions that go well beyond typical tantrums of childhood or grouchy behavior or childhood depression, violent, destructive, aggressive. I'll ask about kicking, hitting, biting, spitting, breaking, throwing. And these children, unfortunately, often have all of these types of behaviors.
Well, Janet, you've been really a pioneer in this area, and you've helped all of us recognize the importance of an early diagnosis of bipolar disorder. But do we have effective treatments for the kids who suffer from this condition? Can we intervene and change the trajectory by using medications?
Mm-hmm. Yes. Well, certainly there are also non-medication interventions as well. But to speak to the medication part, which is my particular area of research and expertise, there are many FDA approved treatments that we now have for pediatric depression, but also for pediatric bipolar disorder. And I guess it's no surprise the medicines that are used in children are the same ones that we use in adults with bipolar disorder. I guess I might say that there's one difference, notably that the group of medicines that we call the antipsychotic medications, they're good. They were designed for schizophrenia. They're good for psychotic conditions. They're excellent for bipolar disorder throughout the lifespan, and they are absolutely our first-line treatment for children with bipolar disorder. These antipsychotics we use, we call them the second-generation antipsychotics because they're new, improved versions of the old-time ones that we have had available to us since perhaps 1950, 60. And we use these new medicines, these second-generation antipsychotics, not because we love their side effects, because I'll tell you they have some awful side effects, but because they work well for the symptoms of bipolar disorder, especially the most impairing part, the rage, the irritability, the outbursts, and they work fairly quickly. Within the double-blind placebo-controlled trials of these for kids, the placebo-controlled part was just 3 weeks long because children would get better within that 3-week period if they were adequately dosed with these medications. But because of the side effects, because of the weight gain in particular that's associated with them, I've been especially interested in pursuing other types of treatments, natural and complementary and alternative treatments as well. So luckily we have a range of things that we have to offer.
Well, thank you so much, Janet. Now I would like to introduce Annabelle, whose son Jack is a patient of Janet's. Annabelle, thank you so much for being here today. Can you please tell us about Jack and the care he has received from Janet? Just your kind of overall impression. We would really appreciate it. Thank you.
Sorry, I have a lot to thank Mass General for. I was in a pretty poor state when I managed to get in touch with Janet. As she just mentioned, there is a lot of misdiagnosis, and that especially happens in the UK. I ended up in a situation where my son had a full-blown hypomanic episode while I was abroad with him. I was constantly speaking to psychiatrists in the UK, in London, who kept saying that they didn't really understand what was going on and that he was far too young to be having a hypomanic episode, and it just didn't make sense. I kept in touch with them, and they spoke to the Maudsley Clinic, which is a massive mood disorder clinic in the UK, and they also didn't know what to help him with. He was 9 years old at the time, and they said the youngest child on record in the UK was 11 years, 7 months. So they had no explanation and no treatment suggestions. I became very desperate and was put in touch with Mass General, who referred me to Dr. Wozniak. And she was an absolute lifesaver, because she said, right, you can come see me. The next day I was on a plane to see her, and within 2 hours she had managed to diagnose and see that actually Jack had been prescribed the wrong medication in the UK. He was put on antidepressants, which probably caused partly the hypomanic episode to occur. So it was a huge relief to me to know that someone out there actually knew what was wrong with my child, because no one in the UK could explain to me what was going on. I was just told he had no empathy, he was a narcissist, he had a personality disorder. They didn't see that actually he was a boy who was really struggling and just needed help. And Dr. Wozniak was the first person who gave me hope that actually my son could have a future and he could get the help that he needed. So it was a great relief. Dr. Wozniak prescribed the medication, and my psychiatrist in the UK agreed to go along with that, because obviously I needed the prescriptions done via the UK. And it has been an enormous help. A lot of the medications that she suggested haven't been used on any child in the UK, even though they've been used on numerous children in the US. And actually, she hasn't just helped Jack, because she's also helped other children, because his psychiatrist has gone on to prescribe those medications for other children and helped them. So I really have so much to be grateful for, because not only has she helped my son enormously, but she's also helped other children via helping Jack.
Well, thank you so much, Annabelle. Janet, before, I just want to remind people that they can use the chat function to ask questions to either Annabelle or Dr. Wozniak or Dr. Huffman, or the the speakers that are coming. So please use the chat function. Give us an opportunity to address all the questions you have. But Janet, can you tell us about Jack?
Yeah, well, it's Jack's one of these individuals that I say the disorder was hiding in plain sight. He had all of the symptoms of bipolar disorder, and it was so obvious, and yet the clinicians who you kept talking to in the UK had this preconceived notion that it couldn't be. And it's been interesting for me to be in this field as part of a paradigm shift, where all of a sudden we are seeing children who have always been there in front of us with these symptoms now in a new way, and diagnosing them appropriately so that they get the appropriate treatments. I always find it kind of astounding when clinicians say, well, I've never seen a case like this. I say, well, come to my clinic and I'll show you 20 in a row. Because when I met Jack, he was like so typical of the children who I see. And I remember that in particular was astounding to you. You kept saying, you mean you've seen this before, you know what this is. And luckily I had. It only can happen that way if we have the time and space to ask these research questions, and to over time have the opportunity to characterize these children and follow them over time. It's really taken 20 plus years for us to feel comfortable saying, we can tell you that this is a valid disorder, and we can also point you towards the right treatments. There's still a lot to do. As Annabelle well knows, it's not so easy to live with this problem. But once you get the right diagnosis and the right treatment, it sets everybody on the right trajectory, and we're really hopeful for the longitudinal course of these kids. The earlier you intervene, the more likely things will go well as time goes on.
You know, Janet, the story of hiding in plain sight of Jack. Reminds me of the thing that also, as a former endocrinologist, endocrinology in some ways, you base everything based on the evidence. So what you see, you call it. If you have high levels of thyroid hormone or low, it's a very it's not based on theory. And when I went from endocrinologist to psychiatry, I discovered the field was filled with theory that someone had come up with no evidence. So, for example, if you're depressed, you cannot be angry at others because you're angry only at yourself. That had been written by some theories, and then I discovered, wait a minute, 30% of the people with depression have irritability and anger. What are we talking about? Oh, no, it's impossible. No one with depression is angry at others. So how do you deal with this with the fact that psychiatry as a field has been filled by all these theories that are not based on evidence?
I think if I hadn't lived through it, I would hardly believe it that so many smart people are guided by pre-existing prejudices that are built on nothing. I even see trainees in their first year of training already having these prejudices inculcated into them as if they are fact. And once you get that, it's actually very hard to switch someone. So it's really important, especially in our training, that we start early and provide people evidence-based training and help them see that maybe if you're operating off a theory, let's remember that that needs evidence-based to convert it into reality. And remember what's a theory, what's a prejudice, and what do we actually have some scientific evidence for in front of us.
Well, thank God you're there to help the field with this. So let's move on to our third speaker, is Dr. Erika Greenberg. She's a terrific child and adolescent psychiatrist here at Mass General, a national expert on Tourette syndrome and related disorders, which commonly include obsessive-compulsive disorder, ADHD, and body-focused repetitive disorders such as hair pulling and skin picking. So, Erika, your program, Mass General, is one of a kind in the country, and we're really happy that you're doing what you're doing. But could you first give us some background on pediatric OCD and tic disorders? And second, talk about your outpatient program for youth with these disorders. Thank you.
Yeah, I'd be happy to. So OCD and tic disorders are brain behavior disorders that often begin in childhood and then frequently continue into the teenage and adult years. Individuals with OCD experience time-consuming and unwanted obsessions, which are disturbing, stuck thoughts, images, urges, and or compulsions, which are behaviors or rituals that are done to help relieve the anxiety from the obsessions. So in youth, some examples that you might see might be repeatedly washing one's hands despite them already being raw and cracked, or seeking reassurance from a parent hundreds of times a day about whether they may have accidentally offended a friend, or turning the lights on the house off and on a certain number of times to prevent a parent from getting hurt or until it feels just right. Tic disorders are when one has trouble stopping one's body from making unwanted movements and or sounds. And examples might be shoulder shrugging or sniffing. And what's really important to know is that OCD and Tourette are commonly seen together, especially in youth, and that OCD impacts 2 to 3% of the pediatric population, and chronic tic disorders such as Tourette syndrome affect another up to about 2% of the population. And so that's over 2 million children who are suffering from tic disorders and or OCD with significant impacts on their self-esteem, school, family life. And we know that unfortunately, if they're not treated, it can lead to severe anxiety and depression. And so when people hear Tourette, they often jump to the swearing or other cursing, other phenomenon like that. But actually, it's only defined as having multiple motor and at least one vocal tic. But it's often the co-occurring conditions that are the most problematic for the child and in turn the family. And while the conditions are certainly on a spectrum, in the most severe cases, one might see a child or adolescent with any combo of tics, OCD, also ADHD, sensory difficulties, learning difficulties, executive dysfunction, impulsivity, rage, anxiety, hair pulling, skin picking, autism features, and/or mood difficulties. And I believe or know that Dr. Colvin is going to touch on why one might see those specific conditions together. But it's a long and can be a very scary list. And so not infrequently, exasperated parents may come in describing a host of problems and concerns that have grown and intensified over time and don't necessarily seem to fit together. But similar to what Janet was just describing, it's sort of clear when you've seen it, and what might be sort of very unique and very isolating for the parent and family is actually typical for some of the kids that I see. And so what we do is talk about how all of these struggles might actually or do actually have a unifying diagnosis under this Tourette syndrome spectrum disorder or OCD, depending on it. And that can be very validating and comforting, as now there's something we can do about it. But that said, while we do have some tried and true treatments for tic disorders and OCD, both medication and behavior, up to a third of patients with PEDS OCD don't respond to first-line treatments. And the medications for tics can sometimes be worse than the tics themselves. And so, and we know that at least, especially in OCD, the treatments haven't changed in decades. So that gives an opportunity to speak more about the PEDS Psychiatry, OCD, and tic disorders program. So I became the director of the program in July 2018. The program was originally founded in 1992 by Dr. Barbara Coffey and Dr. Daniel Geller. And Dr. Geller continues as the director of research in the program. And it's currently a component of the Obsessive Compulsive and Related Disorders program led by Dr. Sabina Willem and the Child Psychiatry Division led by Dr. Tim Willens. Treating children and families with tic, OCD, and related disorders has been a passion of mine for many years, and I've long envisioned developing a team-based, fully integrated, comprehensive clinical research program that focuses on clinical innovation and provides clinical excellence alongside cutting-edge research. And my dream and vision for the program now has been to expand it from predominantly medication-based to one that provides coordinated wraparound therapies and clinical services, both within the PEDS Psych, OCD, and tic disorders program, and in conjunction with other MGH-based clinical research programs. And over the last year, with the help of Dr. Maurizio Fava and departmental leadership, we've been moving towards that goal. And in the last year, we've had a number of successes, which has been really great, particularly in the clinical realm, including growing our team, shortening our wait list, increasing our services, forging collaborative relationships, and integrating additional clinical research. And so just to touch on those in turn, in September 2019, we were able to bring on Dr. Marie Gibson, another child adolescent psychiatrist with mental health technology expertise, and that brought our waitlist from 9 months to 2 months. And we also began working with a wonderful nurse practitioner who can now see the patients for follow-ups much more readily. And the goal is to further increase now Dr. Gibson and my ability to see these new patients. And with the help of Deb Farr, the Senior Director of Development, and SIWA International, a renowned international nonprofit humanitarian organization, and a very generous, grateful family, we just hired Michelle Doust, a social worker with OCD and related expertise, related disorder expertise. And so we're extremely excited about this as we can now provide the often overlooked yet crucial services that a social worker can provide, including education, parent guidance, coordination, and having this will allow for further growth and innovation of our clinical services. For example, groups for patients and siblings and educational outreach. I also quickly wanted to touch on forged collaborative relationships with programs external to us, but internal to MGH, including LEAP with Dr. Colvin, neurology with Dr. Scharf, and child psychiatry with Drs. Hennen and Hirschfeld-Becker. And then finally, one can't further the field without incorporating timely clinical research. And so over the last 6 to 12 months, we've completed a tic-based behavioral treatment study that we intend to publish on soon, are involved in pharmacological treatment studies, and most recently developed a measure to better understand the impact of COVID-19 on the children and families impacted by tic and OCD disorders. And so as we continue to build and grow with the department's help, we can achieve our vision of being a world-class team-based clinical research program for children and adolescents with tic and OCD spectrum disorders.
Thank you, Erika. You know, I love your wraparound kind of system of care, which addresses a problem that affects the self-esteem of the kids, and it's really a significant problem. And yet many practitioners are out there basically say, oh, just take this medicine, not realizing that may not be enough, that only a very small, poor, fraction of the kids can really get significantly better with meds alone. So, you're clearly saying, creating a new model of care, but why is that in some ways? I don't want to say that it's a Cinderella, but the treatment of tics and OCD in children has not had the same resources that other conditions have had. Why is that? Even though, when you talk to the kids, you talk to the parents, these are conditions that really have profound effects on their lives, the quality of life. Why is that?
Yeah, and so I mean, it's a great question, and it's a huge question, because in addition to the limited resources available for kids with tics and OCD, we're also currently in a mental health crisis right now, especially for children and adolescents in general. And so it's hard for everyone, but I think even harder for those that have OCD and tic disorders, and especially for those of lower socioeconomic means. One of the biggest problems being the treatments that we have, especially for tic disorders. There's a behavioral treatment called CBIT that works extremely well, but there are so few providers that are trained on it. It's nearly impossible to find a provider when you need one, and especially one that might take insurance. And so I think it's a combination of a number of factors. One being just in general, the few practitioners that are out there, and then the few in turn that take insurance. And two, similar again to what Dr. Wozniak was saying, inability to recognize oftentimes these disorders for what they are, and then often giving the child the wrong treatment. And a lot of times with tics and OCD, it can look very behavioral, it can look very deliberate. And parents, teachers, family might miss that that's actually, the child is suffering and struggling with these much more than it may appear. And so I think that can sometimes get in the way because it's thought to be behavioral or oppositional. And so what we are going to try to do, or what we plan to do in the program, is to be able to provide this timely, insurance-covered, top-quality, wraparound, comprehensive care for these patients. Adding, again, Michelle Doust will be extremely helpful. And additionally, trying to target different groups. So one of the ideas we have is school outreach, pediatrician outreach, to help teach people how to recognize them so that they can even come to the program in the first place, ideally before their symptoms reach a critical threshold of impairment that then will impact the entire family, and doing more research, ideally precision medicine based, into what treatments might be most helpful for those that have the most severe symptoms that don't respond to the current medications. And finally, training more people in CBIT and those other modalities, so that in turn, when they go into practice like trainees, they can train others.
Thank you so much, Erika. Our final speaker is Dr. Molly Colvin, who was recently appointed director of the LEAP program, working with the founder and executive director, Dr. Alan Bratton. Molly is an outstanding neuropsychologist, nationally recognized expert in the assessment of pediatric onset neuropsychiatric disorders. So Molly, the COVID-19 pandemic has been a catalyst for clinical innovation at MGH, in psychiatry, and at LEAP. Can you tell us about that?
I'd be happy to. Thank you for having me today. My first week as LEAP's director was also the first week that ambulatory care practices transitioned to remote care due to the COVID-19 pandemic. So while the circumstances have been challenging, we quickly saw this as a period or an opportunity to improve how we provide clinical care. By way of background, LEAP provides pediatric neuropsychological assessment services to approximately 1,000 children and adolescents each year. And as Maurizio noted, it was founded in 2008 by Dr. Alan Bratton, who continues as executive director. We integrate knowledge of child development and neuroscience to understand why a child may be having emotional, behavioral, social, or learning difficulties, and then to identify interventions that may improve functioning at home, in school, and in the community. In addition to Dr. Broughton and myself, our clinical team consists of 5 staff psychologists, 2 postdoctoral fellows, soon to be 4, and 2 psychology interns. COVID-19 pushed us to reimagine how we provide care. As some of you know, neuropsychological assessment usually requires 4 to 5 hours of face-to-face interaction so that the psychologist can observe and measure performance on a series of standardized tests. It was immediately clear that we could not fully replicate this in the remote environment, especially in the early days when the pandemic strained so many aspects of family functioning. So by the 3rd week of March, we were providing a new type of service, remote neuropsychological consultations. We've been meeting families with families by Zoom, now through Epic Integrated Zoom, to discuss their concerns, to review a child's prior testing or school services, to explain preliminary diagnostic impressions, and to weigh in about whether therapy, medication, or other services may be needed. Beginning in April, we started performing consultations at an accelerated rate, and we've now reached nearly all families who were scheduled for evaluations between March and October 2020. The feedback from families about consultations has been overwhelmingly positive, a lot like what Jeff was reporting at the beginning. Families have appreciated receiving guidance and input that allows them to start getting help for their child even before the neuropsychological evaluation, and especially during this stressful time. So we're now making remote intake consultations the cornerstone of a new care delivery model. By this time next year, we hope to provide consultations to most families within weeks of the initial referral to LEAP. While this won't help us to necessarily reduce the wait time between referral and evaluation, it will help us to bridge it and to identify high-risk children who need to be seen more quickly. Consultations will also help us to meet the needs of our growing research program. More than 10 years ago, our LOGIC study, led by Dr. Elisa Doyle, began compiling neuropsychological and genetic data. We've now enrolled more than 1,800 youth and have recently secured funding from NIH and private donors to continue and expand this work. Children and families will now be able to enroll in research after their intake consultation, and any information gathered will then be shared with a clinician such that our research and clinical functions will become more integrated. One of the things that COVID-19 also highlighted is that we have very few tools that allow us to quickly and remotely assess a child's cognitive and learning capacity. There are several well-known cognitive screening tools for older adults, but there are really no well-validated parallel options for pediatric populations. So we're now designing a screening measure that will allow us to quickly identify and quantify variability in skill development at the time of the remote consultation, and we plan to start piloting it in the next month. As we look to returning to in-person care while the pandemic risk remains high, we're also developing a hybrid model of remote and in-person assessment. Our staff is working hard to complete preparations so that we can shift as much of the assessment process as possible to the virtual environment. And we're doing this to ensure the health and safety of our staff, as well as those of our patients and their families. So in summary, the COVID-19 pandemic has really helped us to crystallize a new vision for clinical care delivery to allow us to provide services to children and families in a timely and tailored manner while maximizing clinical efficiency and also meeting the needs of our growing clinical research program.
Molly, you're actively involved in expanding access to neuropsychological services. Can you tell us how you're working to expand access? I mean, you mentioned it already, but why is it so important to expand access to the services that LEAP can provide?
So like all pediatric neuropsychology clinics, LEAP has had a waiting list from the day it opened. Neuropsychology clinics are notorious for having long waiting lists. And we accept referrals from within the hospital, like from Drs. Greenberg and Wozniak, but also from within the community. And as such, we're one of a handful of clinics in the region that's really accessible to all families, including those with limited financial resources and from diverse backgrounds. And yet we know that we are only reaching a fraction of those who could benefit from this, to continue to think creatively about new ways that we can apply our skills and our knowledge. And much like what Erika was talking about with wraparound services, I think what we've been really thinking about is how we can use what we know in different settings and in different ways. And in the past few months, we've seen just how much we can accomplish even in an hour or two of consultation that happens prior to formal evaluation. So we now see a role for follow-up consultations that may happen after an evaluation that could address new questions as they arise from a parent or pediatrician, school, or mental health providers. And we're thinking about moving from a one-size-fits-all approach to developing brief and targeted evaluations that answer specific questions, as well as continuing to develop these kinds of measures that allow us to screen for cognitive and learning difficulties so that we can serve more children and families, especially those who have urgent needs for support. And we're really hoping that through these efforts, we can serve more children and families while continuing to develop a world-class clinical research program that understands neuropsychiatric disorders in children and youth.
Well, thank you, Molly. This is music to my ears. You know, it's, I think that it's so important to innovate, to improve access, because we clearly have across the country, across the world, a tremendous problem with access. So you know, as you can imagine, as the chief of this department, you know, I can't be more proud of what all of you are doing to help our patients. So thank you for the creativity, the innovation, the pioneering work. But now I'm going to pass the baton to the master of moderation of meetings, which is it's my friend and colleague Lee Cohen. I do encourage you to use the chat function to ask questions to our panelists. It's a great opportunity to talk with world leaders in this field. So please go ahead and use the chat function. Lee, take it from here.
Hey, thanks so much, Maurizio. First, let me just say how inspired I am and grateful to be working with such gifted colleagues doing such neat, innovative work that informs clinical care and also that really takes clinical care forward. We actually have a good number of questions to sort of get going, but I really have to start by also by thanking Annabelle. Annabelle, I'm inspired by, we've not met, but I'm inspired by your story. I'm inspired by the partnership that you have with Janet Wozniak, that Jack has and your family has with Janet Wozniak. I will say I'm not surprised by that story because I've known Janet Wozniak for many, many years, but I'm still inspired by that story. But the question that came up, Janet, was really about when you think about you know, mood and anxiety disorders, ADHD in kids, the question that got posed was, what does Jack have to look forward to sort of going forward as he sort of transitions to adulthood? And it's also just a more generic question about sort of the longitudinal course of what you've seen in these young children as they get older.
Yes, well, we actually have one of the few, there's really only 3 longitudinal studies of pediatric bipolar disorder, even though every parent's first question is, what does the future hold? And so we don't have a lot of data yet to tell what that will be. What we've seen so far is that the children we followed over time have a high rate of persistence of their problems. So I usually tell parents that we're in for a marathon and not a sprint. And part of that is because children will persist with subsyndromal versions of their mood disorders. They will have cycling in and out of their mood disorders depending on age and circumstances and treatment. And even the kids who seem to remit entirely from their mood symptoms often continue to have difficulty with their functioning, social, emotional, academic. I mean, these kids are often robbed from some pretty critical years of childhood. And so it takes some time for them to catch up and get their feet on the ground. Some optimistic parts to this, though, are that the kids that we've studied so far are children who have had general care in the community, and not expert care, and not necessarily care from people who diagnosed or treated them accurately. So we have a great deal of hope. I don't have the study to show it yet. I'd love to have it, that when we intervene early, proximal to the onset of the symptoms with the right treatment, that like any medical condition, that we can have much improved outcomes for these kids. So it's an exciting time for that. The worry about bipolar disorder is that if it's left untreated, it really can be associated with some of our worst, scariest outcomes in psychiatry: worsening depression with suicidality, substance abuse and addiction, reckless behaviors that can bring children to criminal justice system or get young adults arrested. So it's really critical, not only from the personal, but also from a public health standpoint, that we identify children as early as possible and get them on the right treatments.
Hey, thanks, Janet. Actually, a quick question for Jeff. I missed the days, if someone wrote in, Jeff, I missed the days of actually seeing my doctor. I've had several telehealth visits, and I appreciate it with everything was going on with COVID, but I still miss seeing my doctor. Will patients be able to choose telehealth or not?
I think so. I think we're all making this up as we go. So, don't take anything I say as some kind of, real expert projection into the future. But my guess is that the vast majority of our clinicians are going to do both in-person and virtual care. And I think we as clinicians and patients sort of partnering together are going to figure out what makes sense for people at the right time. Some patients will be perfectly appropriate for virtual care and will love to do it and would love not to have to drive in, and they'll be seen virtually. Some patients will really want or need to be seen in person, and we'll do that. And many patients will probably be a mix. Maybe I see my doctor in person every 6 months, but then I do virtual visits every month or a couple of months just to check in. And so I totally get it. Like, in a lot of ways, this virtual care revolution has been great and allowed us to do so much. But there's really something about the personal contact of sitting in a room with another human being, telling your story, talking about your symptoms, talking about a treatment plan, that can't quite be replicated in a virtual visit. And for some people, that's just going to be too important to pass up. So I think it'll be a mix.
I sit in, as Maurizio knows, I sit in on your meetings, with the various clinical services, and it's not one size fits all. But one of the luxuries that we've had during the COVID crisis has been to be able to, on the fly, have some telehealth visits with patients who are struggling, or or someone may be relapsing, and we get a quick visit in, and that there's a flexibility to the telehealth model that we didn't have before. And so, in a way, I imagine it. I think what you're describing is sort of a hybrid model based on what the patient needs. Different patients, it's not going to be one size fits all. Do you agree with that?
Completely. I think it just gives us so much more flexibility. Even somebody who wants to be seen in person all the time, you can just, dial up a quick Zoom for 5 or 10 minutes if they're struggling, or just if they have a question, and you can give them personal attention while not sort of getting in the way.
Thanks so much. A question for Erika. Erika, I really enjoyed listening to your comments and being down the hall from you, for a long time, and watching you build it has been very exciting. And to see the impact of your work and your team's work on children and families, it's been quite exciting. So congratulations on that. Someone asked though about COVID manifesting in children in the context of the potential for neuropsychiatric syndromes, and particularly, are we going to see sort of a post-infectious PANDAS-like syndrome vis-a-vis COVID in children? And I'm curious, do you have thoughts about that? Either, based on either what you're seeing in the literature, which would be very new, or just based on your clinical experience?
Yeah, I think it's a really interesting question. Similar to what Jeff just said, anything I say now would be more speculative. I don't believe that there's evidence at this point. And in fact, to take a step back, I think we desperately do need more research on understanding PANS-PANDAS and Tourette OCD and the connection between the two. because just to pull back a bit, when I first became faculty at Mass General, I worked in the PANDAS program for 2 years. And so one day a week, I would see a presumed PANDAS patient, and then the other day I'd see a presumed non-PANDAS patient. And so for 2 years, I had those in juxtaposition and comparing and contrasting to one another. And what's really interesting is oftentimes the symptoms don't necessarily differ. One thing I often describe when I see parents with Tourette and OCD and they ask, why is this not PANDAS, is saying, you know, to be honest, there are no great answers at this time. And for all we know, what is Tourette and OCD is thought of as that might have an inflammatory component. A lot of the disorders we are learning now have either inflammatory components or other contributors. And so one thing that's been really interesting is that in a number of cases, I will see a child that has a more typical Tourette OCD presentation that then gets sick, not necessarily with strep, but then develops what others might call PANDAS. And so the way I often describe it to patients and families is you might have what you were already going to have. There might be a genetic predisposition. There might be a reason you're going to develop tics or OCD or whatever syndrome you might have. But in some cases, and we don't know why, and it would be great to know why, in the setting of an illness, inflammation, something, you then see an exacerbation or a spike. And so could it theoretically be possible that you might see that after COVID? Yes, but I don't think we necessarily think it's going to be a major offender versus one more factor that might contribute. And a final point that's just really interesting. Again, a lot of the literature in the last couple of years has made clear the links between Tourette and OCD and infectious disorders, including strep and even non-strep throat infections. And that's outside of PANS and PANDAS. And so again, there's certainly a link somewhere in this realm, infection, inflammation, you know, be what it is, that probably connects all of that. And so that's a long answer without, that's more vague. And in reality, it would be coming in for an evaluation and just really understanding the time course of the symptoms, the family history, the history of the child, to better make an informed opinion, but they're not necessarily mutually exclusive.
Thanks, Erika. It's great. Pivoting to Molly, first of all, congratulations having sort of grabbed the baton from Ellen Bratton during a very challenging time for families and for our community. So congratulations on that. There's a question from one of our Leadership Council members. How do you anticipate new laws requiring children to be screened for dyslexia to impact the demand of LEAP services?
It's a great question. I am actually delighted that in Massachusetts we've passed a law requiring children to be screened for dyslexia. It's something that has been heartbreaking for many years to see children come in 4th, 5th, 6th, 8th grade and who have been struggling with reading all the way along the line and who have never been diagnosed with dyslexia, and seeing how it becomes sort of a major, that missed diagnosis can have such a huge impact on self-esteem and school engagement that can precipitate, a secondary emotional concern. So I'm thrilled that it has been passed. And I think it really highlights the need for these kinds of screening tools that allow us to kind of quickly flag when skills are lagging. We know that dyslexia stems from altered patterns of brain maturation within specific regions. And so there's no reason why we shouldn't be able to pick it up early. And that is really a new way of thinking. I still routinely hear from school systems when I'm talking with them that they can't diagnose dyslexia until a child gets to 3rd, 4th, or 5th grade, which really isn't, it's not true because it's sort of been there from the beginning. And if you know what you're looking for, the early warning signs are easy to pick up often at 3, 4, and 5 years old. So I'm thrilled that the law has been passed, and I think it really does sort of highlight a nice example of where some of these sort of the neuroscience-informed screening tools that come from clinical practice can really meet with policy to quickly identify kids. I also think that I anticipate that what will be helpful is that we're going to have some of that information before kids come to LEAP, and that we may be seeing an increase in kids who come to LEAP. But I also think it provides an opportunity for us to continue our work about partnering with school systems to help explain results. So many school psychologists give measures that neuropsychologists would also give, but they're really only giving them to identify whether a child is on grade level. They don't have the background or the diagnostic expertise to sort of put all the pieces together to understand what's really driving a low score on a measure. And that's the key part. That's the really important part. So I actually do think that we will see an increase in referrals as a result of the screening tools being implemented in schools. But my hope is that that means that we're going to flag kids earlier. So in fact, one of our fingers crossed, I'm hoping we will have a new hire who will actually be specializing in kids who are younger, because I do think that some of our population may shift younger, and we might be able to actually identify kids with learning concerns earlier, which we know will improve the long-term outcomes if they start getting interventions earlier.
Thank you so much. Back to Janet. Janet, how do you diagnose disorders like depression, bipolar disorder, ADHD in children when children's lives have been so disrupted recently with the backdrop of COVID? My child is restless all the time, being cooped up in the house all day. That's a reality for lots of families. And so could you just sort of speak to the challenges of that sort of diagnosis in that context?
Yeah, well, I guess I could say it's really our bread and butter in child and adolescent psychiatry to parse out what behaviors you think should be expected and typical and various ages, but also in various circumstances and under different sorts of stresses. So part of what we would be looking for in circumstances where we're seeing new individuals who have problems are whether the symptoms reach a kind of a level of severity, which sounds above and beyond what the rest of us and most of us and other children seem to be and may be experiencing. So a lot of it has to do with matching up against age-matched peers and what we might expect in terms of the symptoms and severity. The other part, of course, is looking at longitudinal history. Parents are very good at giving stories about their children throughout their lifespan. And so we get a good picture of them, even though we didn't see them before this crisis, we can kind of see them through the parents' descriptions, and that will also help us. I might just add, whether COVID caused the problem or not, if it's a severe problem, we probably need to deal with it and help families and help children function better.
Thanks. Jeff, a question, actually several people wrote in worried about sort of the fiscal side of telehealth that you were sort of describing. And people asked about, can we float the boat financially in terms of reimbursement with telehealth? And actually one of our leadership council members asked about, knowing that so many of us get requests for consultation from across the country, if not even globally, how we're set up to do telehealth across state lines.
Yeah, those are great questions. Fortunately, right now, in the context of this crisis, insurers have been paying essentially full rates for telehealth visits, in most cases including phone as well as video visits, knowing that there are a subset of patients, often among our most disadvantaged people and patients, who aren't able to use video, either because they don't have access to the tools or don't have a quiet space. So we've been really lucky so far that these visits have been reimbursed. And there seems to be some suggestion that moving ahead, there's going to be a strong push that these visits be reimbursed, at least in the short to medium term, if not indefinitely. And a lot of that's driven by patients, people. These are the consumers from insurance companies, and they're saying, we really like this. We don't want to drive in. We actually find this kind of care convenient and in some ways even more helpful in some cases. So we've been really lucky in that way. The across state lines question is a complicated one, and it's actually been differently complicated between medical and psychological agencies, organizations, and payers. But the short story of that still has mostly been is when we've needed to provide care across state lines, it's been okay both medical, legally, and fiscally. Whether that will continue in the long term, we don't know, but I think the more experience we get providing safe care, providing good care, both within Massachusetts and across state lines, there's going to be more and more of a groundswell of support, not just from providers, but from patients saying, I want this, this can help me, this has helped me. And I think we'll be I'm optimistic about the position we'll be in to be able to continue to get these visits reimbursed.
Okay, thanks so much, Jeff. This is actually a question that was asked. This is for the chief. And so, Maurizio, these programs, these incredibly productive, clinically innovative programs cost money. And so someone wrote, the stock market lost 1,800 points today, which I didn't know, but I just checked before reading this question. It did, I guess. And so the stock market lost 1,800 points today. Are you worried about sustaining clinical activities in psychiatry at MGH, given some of the fiscal volatility that is going on across the country and across the world?
Well, it's a great question. I think that in some ways it's a function of how insurers view the importance of psychiatry in terms of the well-being and the care of patients. One of the things that we know is with COVID-19, we've seen a 20% increase in the use of anti-anxiety drugs, antidepressants, and in the request of services. There is a mental health pandemic within the pandemic. So, and usually reimbursements for mental health services pay about 70 cents or 60 cents on the dollar compared to the same visit done by another specialist. So will we continue to discriminate against mental health services, therefore making them less self-sustained? And I think that over time, thanks to advocacy and patients lobbying, I think we're going to see, I'm hoping, a true parity. There's no parity in reimbursements. I got news for everybody. If you think there is parity about reimbursement, no, there is not. And so how do we address that? We've been very lucky that Philanthropy has helped us launch programs. And, in the absence of a true structural support for improvement of care of patients with mental illness, I think I'm optimistic. I think that people will see the light, that even these extraordinarily myopic insurers that have really discriminated against mental health and mental illness are going to finally recognize this, and therefore the needs are there. We can provide the service, the innovations that Molly and Erika and Janet and Jeff are discussing will finally be adequately compensated. And I think we're, I have to think that we're not going to continue to be so dependent on the generosity of all of you, because we'll be more self-sustained. But for the time being, we're still in a phase where we are dependent on philanthropic support because we are discriminated when it comes to reimbursements.
Hey, Maurizio, thanks so much. Janet, to you, my teenage daughter gained 40 pounds on risperidone, and she is really having trouble now getting it off and cannot lose the weight. How did that happen, and what is she supposed to do?
It's a terrible outcome and a terrible story. The second generation antipsychotics like risperidone that are actually so useful for bipolar disorder and other conditions in children and teenagers have this awful side effect that they can cause obesity, weight gain, increased cholesterol, triglycerides, pre-diabetes type pictures. I can tell you that in our clinic, we're so attuned to this problem that it would be I can't imagine that we'd allow a child to go so far to gain that much weight before we thought about intervening. Sometimes you can't, but there are ways in which you can. You can switch laterally to a different antipsychotic or treatment that has less weight gain, or you can co-treat with things that can offset weight gain. I did a study many years ago using a medication called topiramate in combination with a medicine similar to risperidone, and we cut the weight gain in half over the 8-week period that we studied. There's other ones as well that are used for weight loss, marketed for weight loss, that we can borrow, naltrexone, sometimes Wellbutrin. These are all off-label use, but this obesity problem is it has a severe impact on health, so we have to do something. The other part of it is just monitoring. So many clinicians just don't even ask anymore. I usually say that since we're using these medicines, all of us have to become endocrinologists and be hyper aware of this particular side effect. It's not only bad for your health, especially for young people, it's terrible for sense of self and self-esteem. So the answer to the question is there are ways to help somebody who's already gained weight, using medications to help them lose that weight and maybe switching them laterally to medicines that have less liability for weight gain. It's easier to prevent it than it is to treat it.
You know, and one of the things, Janet, that worries me is that I take care of a young woman who had very substantial weight gain on one of the second generation antipsychotics, and she's been successful in losing that weight after a very long journey and a tremendous amount of work. But she really needs to be on the combination of lamotrigine and a second generation antipsychotic, and she won't allow me to reintroduce any of the medicines, even if I promise to work with her collaboratively to see that that doesn't happen again. And so I think when we're talking about young people and also maybe older patients as well, you sometimes don't get another shot, and it takes that whole class of extremely effective medicines sort of off the table in terms of treatment options.
Terrible thing. Some of the studies in kids showed that in an 8-week clinical trial, little kids would gain 10 to 15 pounds over an 8-week period. So this is a problem that clinicians need to be aware of as soon as they prescribe the medication, warning and watching and helping people prevent this outcome.
Hey, thanks so much, Janet. Erika, can you comment? You made reference to CBIT, and we've been talking a lot about digital health, and across our department there's digital health innovation, digital mental health innovations. The question was, can CBIT be delivered virtually and digitally? Is there like an app or something?
So I don't know that it's been reviewed. Actually, I think there might have been one paper on it that suggested it was helpful, but the one that I'm aware of is called tickhelper.com. And just so everyone knows, CBIT stands for Comprehensive Behavioral Intervention for Tics. It is different from CBT, Cognitive Behavioral Therapy, that gets mixed up often. And I think, I know Sabina Willem is leading right now in a lot of the mental health delivery. And so that was something else that we had been speaking about. But Tick Helper is a website I often refer parents to. I think it's free for the first month or two, but unfortunately then it does have either a monthly or a yearly fee. I'm not aware of others, though there might be others. One thing I try to warn parents of is try to the best you can, you don't want to be therapist and parent, because that can end up backfiring, for lack of a better word. So I think the online ones are great, but sometimes you need that extra third person to act as the go-between.
Thank you so much. I want to thank all of our presenters. I want to thank Annabelle again. Thank you for your willingness to come and share Jack's story and the story of your family and your partnership with Dr. Wozniak. Maurizio, thank you for your leadership. I particularly want to thank the attendees for carving out the time to listen to my colleagues and to listen to this discussion. I really hope that you are all safe and healthy, and thank you so much for participating in this webinar as part of our virtual series. Thank you again, and stay safe.
Thank you.